AI is an unknown friend to clinicians, so I'd like to speak about what are the problems clinicians face in their current practice and then try to see if AI could offer any solutions. And I will take the example of the cancer of the esophagus. I would like to come down to earth to speak about the problems we face and how AI could help us. Cancer of the esophagus is a complex disease in a complex patient with a complex treatment. We face a frail patient with an advanced disease, and we have to offer an aggressive therapy. The objective of the surgery is, of course, the resection of the disease and to ensure long-term survival. For that, we should have a safe surgery with a low complication rate and good long-term results. That means a disease-free survival and, of course, with a good quality of life. The key points in the treatment of EG cancer, and I would like later to find what are the problems we face in each step. Of course, we need a multidisciplinary team. We are not just one specialty, one specialist, but a multidisciplinary team with an evidence-based updated protocol with a patient that need to be optimized from the point of view of functional status, nutritional status, comorbidity, anemia, and other problems. We need a standardized technical surgical technique. The volume is a great problem. We are speaking of data. Data from our hospital are not the same that if we are part of a multi-center study. So the minimal volume of activity that we need to have good results is especially important when we are dealing with esophageal cancer. Of course, we not only need to properly treat the disease, but to answer properly to complications, and of course we need registries. We'll speak of that later, speaking about education, but probably we don't have the culture of record the results or record the data we produce. The process is quite complex, but we will need things at every step of the process. At the beginning, we have to decide if the disease is resectable and if the patient is operable. We should offer something else than surgery, for example, radio or chemotherapy. We should rehabilitate the patient. So, I mean to prepare the patient from the nutritional point of view, physical activity or respiratory muscle training, psychological support, and of course treatment and prevention of anemia. Surgery is performed in very, very different ways. First of all, we need to go to the cervical, thoracic, and abdominal cavities. That makes this procedure quite complicated. I come back again to the activity volume, but anyway, probably different teams will perform this surgery in a different way. I mean, probably some of them will resect the esophagus from the abdomen and the neck. Another one will go through the thorax. There are different ways, so the conclusions every team can have are quite different. The extension of the resection, when we speak about oncological surgery, we are not only speaking of resection of the organ, but of the surrounding tissue, and that gives difficulties and more risk, more possibilities of complications. And when we have resected an organ, we have two parts to be put together to perform an anastomosis. This must be performed in different ways as well. In the postoperative control, we need a clinical pathway means to define the normality. Probably we work quite frequently by feeling. Medicine is an art, so I do what I want. but in fact we need a clinical pathway trying to apply at every step the best treatment or the best thing. I mean, in the postoperative period, I should define when the oral intake must start, when the drains or the probes are taken off, etc. We should learn the personnel of the hospital, probably the nursing and doctors and every specialist, to detect in an early phase the alarm signs to treat properly and early the complications. And of course, in the long-term follow-up, we should record our data and to record our survival, our overall survival, our disease-free survival, the quality of life, and complications. This is not exactly from esophageal cancer, but probably this is one of the problems we face. We try to use images to address our surgical technique, but we can have some kind of help, probably from AI, to know exactly where this node or this image is in the surgical field. There are some technical aspects that we are developing, like ICG, like fluorescent imaging, but by the moment we are doing it in a very subjective way. So we look at these images. This is the tubularized stomach. We make the stomach when we resect the esophagus. We use this tubularized stomach to go up to the neck or up to the thorax, and we try to evaluate the blood supply before performing an anastomosis, but this is done in a very subjective way. So we need more tools to clearly know if these tissues are ready to be put together. So what is the problem of that? We spend a lot of time, a long time, putting data personally out of our working time. How the clinician use her or his working time? In fact, a surgeon probably spends 30% of his or her time in the operating theater. Then he has to spend time at the external ward with the admitted patients at the emergency room. So there is something like 10% of his time to do this office work. In fact, we need to assess our practice to know and to improve our outcomes and to take decisions. So I wrote down there, please AI, give us time, help us to better to use our time in a better way. This is a record, a registry we were working in last year, but we need that, but probably we spend a lot of time introducing data, but that's what we need in our current practice. We must know where is the relationship between some kind of some type of anastomosis or some type of approach, if we have more or less complications when we go through the thorax or when we perform this anastomosis mechanically or hands-on. Okay, so I tried to put all this information together just to know what do we miss or what do we need. Of course, the first problem is how to collect data easily from clinical records. We have a lot of text from a lot of specialists when we face one of these patients. It's not easy at all to select the information we need to follow up these patients. We need to reduce delays. The patient is going from one specialist to another one, having images, going to perform a CT scan, then to the PET, then an endoscopy and a lot of things. To obtain reliable information for diagnostic tests, we'd like to know exactly if a patient with a CT scan has a resectable disease or not. With the data we have, we could maybe have this information. To integrate diagnostic images with the surgical field, with the operative field, is another thing we need. To reduce errors due to human fatigue. I use the example of esophageal cancer because we spend several hours in the thorax, in the abdomen, in the neck. So probably at the end, the probability of success depends in a high degree of the fatigue of the surgeon. To detect early signs of complications, to give the importance, the necessary importance to the results of a laboratory test or to an image performed, to know, beware, we may have in front of a severe complication. To analyze and interpret our results, to compare results with others, to predict outcomes, and at the end, to improve with all this data, with all this analysis, to improve our selection criteria, our circuit, and our protocol. And of course, and that I would like to end with this phrase from this publication: physicians and machines working together have the greatest potential to improve clinical decision-making and patient health outcomes. So that's some kind of introduction.
Okay, so now that we've seen how actually clinicians could be helped a lot, especially surgeons, with artificial intelligence, we can give maybe pace to Dr. Iñigo, and you can tell us a bit more about, in your case, in being a neurologist, how would artificial intelligence help you as a clinician?
Yes, as you said, I will speak a little bit. I will provide an overview or a perspective of how neurologists, we think every day, and how we see our specialty from years has been developing. So probably we are one of the specialties in neurology that are more based in the clinical interview and the physical evaluation of patients. So clinical history is still extremely important in neurology, since we still don't have enough biomarkers that are accurate and precise enough to be incorporated with evidence-based medicine in the clinical routine. So we first have, it's a kind, we still, like in the origins of neurology in the 17th century, they thought that clinical observation was the key for diagnosis, and we still work on that kind of approach, incorporating technologies like imaging or neurophysiological tools or biological markers from blood or CSF. So what we do is to have an interview with the patient, and here it's very important to know the temporal aspects of the disease, if it's acute onset, subacute, or chronic, if it's episodic or if it's continuous. And that kind of description of the disease gives us an overview and helps us classifying the symptoms and the disease in one type or the other. We also have into account, and it's very important in neurology, we always have in mind the localization, anatomical localization of the problem. So when we do a clinical physical examination, we try to locate in which part of the nervous system is the lesion or the problem. So basically what we do is to create a kind of textual information of what's happening with the patient. So the thing is that what we really need is to the problem with neurological patients is that right now the tools that we have are not, as I said, they don't give us. We are still working with all these, I said, signs and symptoms that we can describe, and we are still working with what we call a diagnostic clinical criteria that have been evolving with time, and now they are based on consensus of guidelines of experts. And now we are starting to incorporate imaging and biological biomarkers to those criteria, but we still lack accuracy and precision for diagnosis and for classification. So one of the main problems that we face is that we have problems with the classification of patients. Even if we need many times follow-up of patients. For example, if a patient with cognitive problem comes to the clinics, in the first evaluation we are not able to provide a diagnosis, and many times even after several visits and imaging or biological tests, we don't really have the specific classification. So what I think that and another thing that we also use is the classification of the syndrome based on the signs that we are detecting. So they can be a motor sign, like a motor deficit, or a sensory sign or symptom, or cognitive problem. So what we would like, would need is a system that is able to incorporate all this information that we are gathering to make a more accurate and precise diagnosis of patients. Because, for example, Alzheimer's disease or Parkinson's disease, we now know that the evolution is, there are many types of diseases, and the evolution, there are more benign phenotypes, more malign phenotypes, and we think that probably there are, with these classification approaches, based on not only what patient is declaring, not only in which from the information that we are gathering from the physical evaluation, but mainly from objective measures taken from sensors and taken from biological samples. All this information could provide a more biological diagnosis, more specific in terms of biological phenotyping, and that would help first to select a more specific treatment for patients, to establish a more specific or personalized follow-up and rehabilitation programs. So yes, one of the needs is to create paradigms that are able to gather not only the information that we write, that is reported from patients and that we detect in the traditional clinical evaluation, but also those technological and biological biomarkers to improve the accuracy and precision in diagnosis. And probably also for monitoring, we have many difficulties because patients, the disease is dynamic, and during the course of the disease, we only see patients once or twice a year with luck, and probably with sensors and other wearable devices, we can have the recognition of patterns, because the information that we gather in the, as I said, I'm speaking a lot, I'm sorry, but as I said, the information that we gather is still traditional, and it's very prone to subjective variability, and the objective information that is coming from sensors not only can provide more consistent data, but also a continuous tracking and pattern depiction of the disease. So not only we need classification strategies for diagnosis, but also for tracing the different patterns of evolution, and of course for selecting best treatment strategies depending on such phenotypes. And that's mainly, so the system that gathers all these approaches in one.
Okay, so now that we've seen that actually, it's very different for a surgeon than for a neurologist, what they actually need for artificial intelligence, we also have to consider what's actually possible, and that's why we brought an engineer to this roundtable.
Okay, thank you. Yes, thank you for the introduction. Is it working? Yeah? Okay. So thank you for the introduction, because this is true that you have presented two different points of view that are completely different. And from the point of view of the engineers, I think that is also a completely different point of view. In fact, when I have to face to this kind of problems, because I work at the university, it's easy to use machine learning to solve standard problems, to generate new algorithms. But when you have to face a real application, the first thing that you have to do is to sit down in a table with the expert in the problem and to define the problems and the challenge that you have to solve. As Jorge has introduced this morning, define a real problem, a real challenge, not create new needs or not define things that maybe we think that are easy to solve, but define a real problem that has an additional value, in this case for the patients, for many, maybe an economical revenue, but that has a final impact. So from your introductions, maybe in the health field, we can define that in most of the cases, the goal is, okay, maybe I want an algorithm to be able to classify patients from different kinds of disease, okay, to know the severity of the disease. Maybe something that is more interesting or is more challenging to know the characterization of the disease, to be able to define biomarkers, neuromarkers, which input features are the relevant for the definition of the problem, the treatment, the adequate treatment that I have to use. Can I have a follow-up of the patients, okay? Can I know the real treatment, how it's going to affect the causality that is inside? If I decide, or if my machine is taking this decision and I apply this, how it's affecting to the patient? So these are real challenges that I think that from the point of view of the engineer, we can define by ourselves. So the first thing that we have to do when we try to apply machine learning in any application, and mainly in health applications, is sit down with the expert. Let's gonna talk. Let's gonna discuss what can be interesting, and let's gonna make an effort to define a real problem, a challenging problem, and to solve something that's gonna have a real impact. Let's make that the solution that we can provide can be useful for the community. So I think that in many cases, this first step is something that we forget. I don't know why. You say, okay, we have maybe this data, and let's gonna do algorithms, let's gonna use this, because I think that is something that Dr. Desco has pointed out. There are many toolboxes that many people can use, but sometimes we don't stop and we don't think what we can really do with this, okay? After that, okay, we can define the challenge that we want, okay? We have already stated the problem. It's very clear that maybe what we want is to define or to find biomarkers for any mental disease, okay? or whatever other applications, but I think that the next challenge that we have to face is the data acquisition. Because, okay, we define this problem, and the next question that the engineers have to do, okay, which data do you have so that we can work? And that is the next problem that we have to face, because in many cases, okay, you say, okay, maybe I have I have been collecting data for 4 years and we have 100 data. And you are thinking that this is gonna be a lot. But for us, it's not useful. We're gonna face all the problems that Dr. Desco has focused on. We're gonna have overfitting problems. We don't have data from different centers. So what we have to know is that the data is the value of all these algorithms. If we want to make this work and to obtain accurate results that really have a real impact, we need not only a huge amount of data, but we need multi-center data. We need heterogeneous data with started in different conditions, with noise, something that's gonna be real with the final scenario where we want to apply all these algorithms. Otherwise, I think that the only worth on the real impact of this maybe is to get a couple of papers that maybe we publish these algorithms for these applications, that we see that this kind of technology can be useful, but we don't have a real impact because we cannot check the usefulness of the algorithm in a real scenario, and we don't check all the issues that Dr. Desco has pointed out, because we cannot check that in a real application with new patients, in a different conditions, in a different hospital, is going to be working in the same way. And I think that that is the key point to get an innovation in all this chain. After that, imagine, okay, we have already defined the problem, we have already access to the data. Imagine that we're gonna have a lot of data from different centers, so everything looks fine, okay? So then I think that is when the role of the engineering, of the data scientist is there, because then we have to decide which kind of algorithm maybe is better or more suitable for the problem that we're gonna solve. Okay, we have a lot of tools. Okay, we have from standard machine learning algorithms, maybe decision trees, super vector machine. Okay, we can go or move on to deep learning models if we're gonna have a lot of data, and okay, maybe this is working. But depending on the needs, okay, maybe we need more interpretable models. Okay, so from my point of view, if you have a easy problem, the simplest model, the better solution. So try to do the things easier, and maybe using deep learning is not the best option. Always, if you can solve this problem with a linear model, use it. It's going to be perfect. And it's going to be better because you can explain the result of the model, you avoid overfitting risk, and those things. If the final goal is to get interpretability, from the beginning, think that you need that. So maybe it's better to use a model with some kind of feature selection or some kind of linearity so that you can interpret the features and the way that the model is working. Okay, so sometimes maybe I think that there is always a trade-off between interpretability and accuracy. And we have to choose, okay? In one side, we prefer to move. So maybe I prefer to reduce the accuracy if I can interpret the model best. So I think that that is another important point. And something that we can't forget is, okay, I have my problem, I have my data, I have my model. I have already trained the model, it's working, but we cannot forget that after that, we have to go back to the expert. We have to analyze the result, okay? This is my machine. My machine is providing these results. And now, tell me, this is what you were expecting? Is this already solving your problem? I am providing you the biomarker that you were expecting. Okay, the biomarkers are related with the expertise that you have. Is this making sense? Or maybe there is something that there is wrong, or after this, can I check my model with another data set with new data. The point is, let's gonna validate the model not only on the data, but also with the expertise of the field. So if you realize in all these steps, we are all the time, or we have to be all the time working with the experts of the field. We cannot forget that maybe we are engineering, we are experts in machine learning, data scientists, deep learning, whatever, but we need the advice, the supervision of an expert that can help us, okay, to maybe to understand the problem from the beginning, but also to analyze the results and to validate the model. With that, I think that more or less we can train or we can apply machine learning to every problem that you may have, but we have to think about the problem, we need the data, and we have to work together.
Can I tell something? Okay. One of the things that I think is a key here in the work between engineers and us, clinicians, is that engineers should know how each specialty works. So which type of that data they manage. So maybe in our case, neurologists, we work, as I said, with clinical interview data, and so this is written data. And now we are incorporating sensors, and that's objective and more consistent, as I said. But and maybe we will speak about that later. But maybe you have to train also clinicians to start creating data or using or adapting data to the strategies that you are using. For example, in medicine schools, now it's people speaking about trying to train students to write properly in words and language in clinical records that can be interpreted. No, so and for example, ophthalmologists, they work with images all the time. So I guess for an engineer, that's easy to it's straightforward to work with that data. But for more straightforward that with neurological data, because in the daily practice, we work, as I said, with clinical interview and with physical examination, and we add to that the imaging data. But that doesn't make the diagnosis; only helps in the diagnosis. So, and in other specialties, maybe I know in digestive system, you combine probably clinical and also imaging data, and also, so that's to adapt to the specific way that each specialty works, and to train the clinician so that they provide you data that is valuable for your algorithms. So I think that's a key point there.
I was thinking about data. I think there is a very important thing. Frequently, we don't have data. I think for low incidence diseases, we need multi-center registries. That's very, very difficult to have registries. Common registries or multi-center registries is very, very difficult in this country, in the public health system, and to take out some items to be analyzed from the clinical records is very, very difficult. So there is, first of all, a culture. I need to record data. Secondly, I need to make my decisions not only from my 20 or 30 cases a year, but from all the experience in the surrounding hospitals or in the country or something like that. And that is more difficult because we need a specific consent that comes from the field of ethics. So we come back later. But we need just to record something from one patient and to put it in a multi-center registry. We need a specific consent from the patients. In the Basque Country, I think it's especially difficult because if you add an item, you have to pass the decision to the committee again and something like that. But that's one of the big problems. I think we are now in a good situation. We understand the needs of recording data, but that's something like a first step to be to be convinced.
Yeah, I completely agree with you. So I think that the real challenge is the data acquisition. So I don't know if I am the right person to talk about the ethical problems because I'm not expert in the health community, and there are many law issues that I don't know. But what is quite realistic is that if we get that doctors from the beginning in their degrees, they start to know how to acquire the data, how to record this, to homogenize this, it's going to be a great helpful, because just the standard clinical the record that you have of a patient in the doctor consult is going to be that is just test. Maybe you can consider that is just test, but trying to include some fields that can be common, that the report is recording with some kind of detail, trying to include information that they already know that it's going to be important for the following analysis, and those kind of things is going to help all the algorithms that we can use later. And not only for the clinical report, even for the image recording. I think that maybe there are some protocols, but when I have to face or I have to work with this kind of image, I face that the image from 1 year have this kind of preprocessing. Next year they have used another preprocessing. Later, maybe ones are in one kind of format, another in a different format file. So trying to combine image, even from the same hospital, the same group, but from different experiments or different projects, are acquired with different protocols. So I think that at some point we have to try to unify this, or have some way to come back to the raw image and maybe to apply ourselves all this post-processing. And I think that to get if we go to break all this, we need that doctors on one side have some kind of knowledge on this stuff, but also the data scientists need also some kind of knowledge about the problem that they have to solve. I know that there are many problems, but at least some basic knowledge about the kind of data. This is this kind of image. You can find maybe artifact in your image. Maybe you need to apply some kind of preprocessing. You have to take into account that this data is acquired with this protocol, this kind of things, how to deal with this kind of files, different images, different specific software that you are familiar with that to visualize that, but for us it's completely new. So I think that this is something that is going to help that both worlds that at some point are quite different come together, and we can start to work more efficiently.
I don't know which will be the future of clinicians, because the ones that are more working already with data that it's easily analyzable, like radiologists or neurophysiologists, in my case, in neurology. So they are thinking of what will we do with our work, because the AI or the machine learning strategies will probably, this is different, the radiologist, the neurophysiologist from the neurologist, that it's directly treating with the patient, that has to communicate and has to advise and follow up from the, let's say, human and patient clinician relation perspective. So I don't know if clinicians, we will have simply to tag, put some tags in terms of clinical depicting, and then we will use technology to obtain data from that patient. So I don't know where we will be in terms of this field, but...
From my point of view, I think that all this technology has to be considered a tool, a help, something that it has to be your life easier, something that has to help you. I think that maybe in other fields or in other kind of applications, you can think that a machine can be good enough to detect objects. In fact, computer vision, the result that you have can be better than a human. No matter if you have a machine working in Google, just looking at pictures and tagging that in this picture you have people, you have animals or whatever. And no matter, because if the machine fails, okay, that this label is wrong and it's not happening anything. But here we are working with lives. So I think that the point that a machine is eliminating the role of a person, I think that is something that, at least me, I can think in that. So I can think in this technology as something that maybe if you have to check 100 of images every day, maybe the machine is telling you, okay, these are the ones that I think that are most risky. Maybe you have to analyze this in detail. Maybe you want to maybe redo some of the tests or whatever to maybe to check the patients, whatever. And these ones, I think that are healthy ones. Maybe you can go faster. But I don't think that the point is, okay, now this stuff is going to be done by a machine without any kind of supervision, because the risk of any fail here is it can be alive.
I totally know, but there are some specialities that are more easily.
So I think that maybe we are thinking in the machine learning, artificial intelligence, and those kind of things that, okay, maybe at some point they can do things that experts or human people were doing. But in some kind of tasks, I can't believe it.
Okay, thank you very much. Now I think we can open for a few questions. If there are people in the audience that have any questions relating to this topic of how we can help clinicians.
First of all, sorry for my English. I think it's not the best, but I will try to do my best. My question is for Dr. Iñigo, because I think that is related with your field. And is also related with the diagnosis field that we, the machine learning engineers, face, and specifically with the psychiatric field. And when we face this problem, I think that the main problem is when we try to set the labels of the different patients, it's really difficult to ensure that these labels are well labeled, because there are a lot of studies that comes from good universities and good hospitals like the Johns Hopkins hospitals that say that, for example, the 60% of the depressive patients are not depressive, and there are a lot of disorders that have a lot of misconfusion between them. And my question is, what is the best protocol or the best methodology that the clinicians could follow in order to make us to trust that these labels are well labeled, are not weak labels, and we can set these labels to our models in order to extract good conclusions?
As I said, also in psychiatry and in neurology and other specialties also, the labels are put based on, first, the clinical experience of such clinician. Sometimes, many times they use clinical scales, but such clinical experience and clinical scales are based on subjective aspects, and of course in the training of such clinician and in the experience. Some of scales, clinical scales, are some, let's say, certifications that are based on a specific training, and with that certification, in theory, and with a long experience, that clinician should have more consistency in his measurements compared with other and compared with himself. So that level should be more reliable than others, but always there's a variability when you are using clinical scales, when you are also using words, when you are using, you are basing your biomarkers or your data on the levels that a clinician has put, will always have variability. So the best way to decrease such variability is to use objective biomarkers. In psychiatry, it's very complex because most of the data comes from the interview. So maybe from imaging biomarkers combined with biological blood test biomarkers or cephalospinal fluid biological biomarkers. And if you combine such biomarkers that are more objective with the more subjective levels coming from the clinician, you will provide much more reliable classification. So multi-biomarking should be probably the best approach. I don't know if I answered your...
Yes. Thank you.
One more question before we move on to the next.
I'm going to say something. I would like to contribute to what just Dr. Vanessa Verdejo said, that I don't think, I also work in applying deep learning to radiotherapy, and I don't think that artificial intelligence is never going to replace a doctor. I mean, I think you specialists have to be open to working with artificial intelligence because the objective is just to make your lives easier. So, for example, I work with radiation oncologists and with radiologists, and we work on reducing the time for segmentation, for example, for head and neck cancer patients. So instead of spending 2 hours per patient segmenting, we do it in 5 minutes. And we give the doctors an accuracy map, a precision map, so they know which pixels they should review, but never substitute them. So I really think you have to be open to that field, because I think it's going to actually make medicine easier for you, and so you can spend more time with the patients and everything.
No, I was not really trying to say that AI will replace clinicians, but some specialties will be more affected or more, I mean, clinicians at such specialties will have to change more their roles than others. So, like radiologists will have to think on how they can complement with these approaches more than right now neurologists. Right now, we don't have tools that can replace our work right now. Maybe in 10 years, yes. But I also think that won't replace clinicians. We will always have to interpret the result coming from AI and always have to communicate with the patient and have empathic approach with the patient. The AI will never will do that. But our roles will shift for sure. So we will have another roles, yes.
Okay.
Okay, if there are no more questions, we can move on to the next section, which will be about ethics in artificial intelligence. I mean, each of you can have a short 2 minutes, 3 minutes to talk about any aspect you like. I mean, you've already talked about getting consent, also what about biases, what about who is responsible finally for, I mean, the decision is made by the doctor, but how does the doctor trust the machine and so on. So whoever wants to have a go first.
Okay, there were several topics. I will select one. This is not really related with those, but it's something that really concerns me. That it's the use of data by not only private but also public institutions for research or even for selling such information, and that's something that is happening right now. And I don't really know what will happen because they are now they are creating like artificial intelligence centers, institutions that are working with tons of data. But from the ethical point of view, they say, okay, we will anonymize such data and the patient won't be identified, but the patient didn't give their consent to provide such data, for example. So there's hundreds, millions of data that retrospectively come from digital recordings. And my question is there any regulation on that? Because I know that several governments are providing anonymized data to public and private companies.
Maybe I'm not the expert on these topics, but I think that we have to start to make this regulation. So I think that the problem is coming at the beginning from the use of the data. So can we use this data? The anonymization is going to be enough because we are working with data of people, but personal data at some point, because maybe you can say, okay, I remove the DNA, I can remove the name, the surname, and maybe I include an ID. But if you have the genetic information, you have the key of that person. So that is more informative about that person than having the name or whatever. So we have to think how we can deal with that. If it's gonna be enough to have a paper signed by this person saying, okay, I don't mind that you use my personal information because it's gonna be for what? Because it's gonna be for maybe for research, for public use, no profit. Maybe the patient agree with that. But if it's gonna be used for a private use to earn money, maybe you don't agree with that. So I think that we have to start to that point, and something that we have or we're gonna face in a few years is, okay, now that I can use all this amount of data and I have my algorithms, now in case that my machine is not working, who is responsible of that? So it's something that for the engineers is something completely new because we have never faced to this kind of problem. Maybe people from the medical community, you are familiar with that because you have another responsibilities. You already know what is a ethical committee. You know how to deal with all these things. But for the engineers, this is completely new because we design algorithms. This is providing outputs. Maybe I can sign a document maybe saying that, okay, my model in this environment, maybe with this data, I can assure that it's providing this kind of results, and maybe. So I can promise those kind of things. So it's something that we're gonna have to face, and I think that as we usually do everything in this country, we are already late for that. So we have maybe start to think about all this stuff. Starting, I think that for the use of the data, because it's gonna be critical if we want to really develop useful algorithms, and later start to think that what is gonna happen later. And in that point, I think that we can come back to the above discussion. I think that in this kind of applications where we are working with lives, the decision of the machine hasn't to be given alone. So we need a supervision there from an expert. And I think that we can, with this kind of joint working, okay, an algorithm that is only helping, maybe we reduce the risk and we reduce part of this legal issue. But just my point of view, so.
I am very, very concerned about the use of information. I think we need regulations, but they have to be quite flexible. It's difficult to explain, but we need to know what are our results. I think it's part of my profession to know if I have operated on 500 cancers of the stomach, I must know what are my results. But to say that, I need the specific informed consent from each patient. So now I can't publish what are my results, but I need that. I need that for me, for the others. And I think that's one of the key questions. We are quite limited by the fact that we need an informed consent. When I face one patient that comes to me with an esophageal cancer, I give him something like I should give him some kind of informed consent for operation, for anesthetics, for the information that is recorded, for the blood transfusion, for the record of the multi-center registry or something. I think it's very, very difficult in the practice, very, very difficult. It's necessary, yeah, but we need just to adjust these tools to have information to improve our clinical practice. But it's very, very difficult in the daily practice.
There's something I want to add to this. We have to, and I said I was like speaking against this data use, maluse, but I would like also the institutions and authorities to support the creation of digital biobanks of data. For example, UK is a worldwide example for that. They have one, if not the best, one of the best biobanks in the world, and they have digital data, imaging data, sensor data, biological data. And here in Spain, we have different tissue biobanks or biobanks with biological samples, but we don't have strong or big biobanks with digital data. For example, Jesus Cortés can speak about one project that he led to create a imaging biobank that received information from the daily clinical practice. So the patient, when the patient went to the clinical consultation, the clinician said, do you want your imaging data and your clinical record data to be integrated in a public biobank? And he just said informed consent, and that was, maybe Jesus can speak more about this, but there's no public support for this kind of, because this kind of biobanks are very, from UK Biobank, there have been hundreds and hundreds of publications, very valuable. So I don't know if Jesus wants to speak anything about this or not, if you don't want to speak.
So this was just a pilot kind of study that we kind of imitated what was happening in UK Biobank at the Basque Country level. So we had to focus on neurodegenerative diseases, Parkinson and Alzheimer. So we tried to just imitate, like there is a medical record, but also there are some images. We could put the raw images and also processing of the images into that. So we arrived to a cohort of about 100 patients, more or less, and we wanted to put it in the Basque Biobank, the one with biological samples, but that thing of putting the images in there, we couldn't, finally, because many regulation, administrations and things. So eventually, technology by far is there, but it's not easy to really go there, because then Osakidecha was saying that data belong to Osakidecha, but then it's another institution, which is and it's really complex, that.
And it was not only an effort for research, but also for innovation, because what you also were trying is to provide to the radiologists a processing of images so that they have some quantitative data directly instantaneously, after acquisition. So it's a really good idea, and the project didn't continue really, but I can say the support didn't continue from the public resources, so I don't know.
obviously there is a regulation issue that we have to deal with, and I don't know if anyone has questions or any other concerns they would want to raise. No? Okay, so then I guess we can move on to our last topic today, which, I mean, you've already previously discussed a bit, and that would be whether we should, in some form, include artificial intelligence in the medical curriculum of medical students or medical residents. Whoever wants to take the floor.
I would say, of course, yes. I think is the base of my thinking. We need to know AI because that forces us to organize our head, organize our data, analyze what we are doing, and to extract conclusions from a lot of data. We need to know that, of course, and we need to have the tools, not to spend a lot of time. There are a lot of tools that we don't know, and of course we need to know what we are doing, how our patients are going, and so for me it's very, very clear. It's very clear.
I completely agree. In fact, I think that one of the main challenges that the engineers have when we have to apply machine learning in these kind of applications is that we talk different language. So maybe we spend hours talking or trying to understand what you are talking in one way. How can I translate this, or what is this in my field? And this is making the things quite complicated and is doing everything harder. So I think that, of course, doctors, if they can study something related to machine learning, artificial intelligence, something that makes to understand what we're gonna need, is gonna make everything easier. But I would like to go one step over, because I think that we have to have engineers, people that have knowledge of both fields. Okay, so I think that the successful of this is having biomedical engineering with a data scientist knowledge, or data scientists with knowledge of bioengineering. And I'm not here to talk about my book, but at some point, that is something that we are already doing at our university. My department and Dr. Desco department, we are working together with a master just to get people that is joining the knowledge of bioengineering with the knowledge of data scientists, and we are working in this way for 3 years. And I think that the students of the first year are really brilliant students. They have a lot of new opportunities, and I think that is the way to get success in this kind of applications. So, of course, we need to include this kind of education in the degrees, but maybe we can go even more. Okay, so I think that the ways that we have or we can explore are a lot, and this kind of interdisciplinary education, I think that at some point is going to be the future.
I totally agree. I think that students, medicine or health students, have to integrate the idea that they are data acquisition machines, and they are working with data all the time. So they have to be aware that the type of data, the quality of data that they are using is really essential for new approaches to be applied. And to understand such approaches, also they have to understand a little bit about how they work. As I said, there are some proposals for example, to teach students to write in the proper, with the proper keys, or to know that what they are using when they are writing the electronic clinical records, they are really creating data. And here also, I don't want to sell my book, but in the neurology, Spanish Society of Neurology some years ago, 5 years ago, we created a committee, ad hoc committee for new technologies, and I'm part of that committee, and I think that in different societies, clinical societies, are creating such committees, trying to gather all the proposals and the initiatives from clinicians from the technology standpoint, and also trying to teach clinicians in machine learning methodologies. Also, another key point here, I think that is the most important part, is to bring bridges between engineering world and clinical world, just conversations, congresses. So if I speak with an engineer, I'm sure that in 1 hour we will find possible solutions that we can test for 5 or 10 problems that we have. So what we need is to create common spaces in which we can just speak or share what we do, what we need, no? So that's the best way. So many times I think that engineers are working, they have some ideas on the diseases, they start creating technology, and their technology is not really useful because they didn't have a conversation and a work with the clinician. I'm participating in an European project with engineers, and the most difficult part, and that's the 4th year, it's about rehabilitation in chronic diseases and based on technology. And the most difficult part was to get understood by engineers, and that engineers understood our language. So it took 2 years so that until we reached a point in which we could speak and use the same language. So I think that's very important for medical careers, yes, to integrate this.
That was already a problem between the recent divorce between inside medicine, researchers and clinicians. So now we are going to add engineers there, so it could be very, very interesting. I hope we will have some results. But of course, we need to know what the other one is doing. Sometimes when we perform some kind of trial or something, we have the researchers saying there is no evidence of that, but we know that in clinical practice we can see that or that. So, but that could be a very, very interesting work. Yeah. to listen to each other and to go together, of course.
I mean, being here a bit of a devil's advocate, the medical curriculum is already very extensive. I mean, it's 6 years instead of 4. So isn't it a bit unfair that we're sort of putting pressure on doctors and to know more about artificial intelligence, but then we're not included in medicine in the engineer's degree? Or kind of can we expect, or how can we integrate this knowledge without being another module that doctors have to take during their medical training, just go past it and nothing more?
No, it's not a module. It has to be cross-sectional, transfers to every year teaching. So it has to, I mean, the teachers have to have that kind of perspective from the beginning. Now, in fact, the new here we have University of Deusto. No, they created a new medicine faculty, and they started from the scratch with technology and digitally based learning. So that's probably the old-fashioned, let's say, universities are trying to implement this, but with the new universities, they know from the beginning that they have to incorporate this training.
For the whole day today, you have been convincing us that with that tool, the other things will be easier. So it's very, very interesting to put that into the medical curriculum, because the rest of the things will be easier.
I know that studying 6 years is going to be harder. There is no doubt about that. But I don't know the exact curricula, but I think that it's hard to think that in 6 years it's difficult to find maybe a slot for 10 seasons or something like that, just to know the basics, just to know what maybe is important or not. Maybe some kind of transversal, including some kind of lab sessions or practical issues where you can realize about this at the same time that you are learning another course or something that can be related with that. Maybe when you are learning about the image acquisition, PET scans, whatever, maybe at the same time you can deal how to treat this data, how to save it, how maybe just to know that maybe later there is a black box, that we don't want to say that it's a black box, but that maybe it's a black box that can deal with this, and if you want to make it work, maybe it's better to use the data or to save the data in this way. That when you are recording the data of the patients, maybe it's better to try to be systematic and to save this kind of information or try to explain the disease or the treatment or to include some kind of variable. So maybe it's not so hard, but I think that maybe the key point is what you were saying. Maybe the change in the mind of the teachers, or maybe the way that we are right now teaching some of the courses. But it's just my opinion.
I can give an example because I'm teaching in biomedical engineer grade physiology, and I'm using the level of complexity probably I used in my career, so it's quite complex for engineers. It's second course. And I'm using the traditional way of teaching physiology. And I'm in the fourth year, I'm doing it, and I'm saying every year, I have to change the way I teach this. I have to, and I'm like using the way I learned with the traditional, but maybe 1 year I will dedicate 3 months to change, try to transform a little bit and to integrate technological approaches in all the lessons because in the career we learn the traditional way of medicine, not the new.
Yeah, we are not here to speak about university education, but in fact we have to change a little bit. Theoretical questions that we can read at home or anywhere. Probably we have time enough to open our minds to the new things that are coming, and we should reorganize in some way to focus on problems rather than in theory and so on. Probably the university, the teaching at the university must be focused on more important things. I mean, probably we should change a lot of things, but I'm convinced we have time to introduce new technologies, new tools, AI and so on. Of course, in surgery, you have a big curriculum like that, and you could reduce classes, interaction, presential classes to things much more practical, and introducing that. I'm no doubt of that.
The thing is that I think that clinicians, we don't perceive yet the artificial intelligence as something useful that we use in every day, so that we don't integrate it in our explanation of diseases or the way we work. So, like, I don't know, like the iPhone, when the iPhone came and transformed the way we use smartphones, if something changed really the way we work, we will probably start explaining how we work based on this. But right now, I guess that it's quite complicated. Maybe some people like us that are interested on that may explain that way, but it's complicated, I guess.
Anyway, I think that not only medicine, I think that any degree has to be evolving with the career. So the society is evolutioning, AI is here, it's coming for being part of our lives. So I think that in any degree we have to evolve, we have to adapt to the new technologies and the things that we are coming. At least me, that I am teacher, I have to adapt every year the material that I use, because I am teaching machine learning. The machine learning of 2 years ago is quite different from the one that we have right now. And if we want to teach students the new tools, the things that are current, useful, we have to adapt the material, the content to the new things that are coming. So I think that that is the goal of any teachers, and any curricula of any degree that is worthy to be studied has to be updated. So I think that there is no doubt about that.
Are there any questions from the audience about anything? It can be about this, it can be another question that you want to ask one of the speakers. Over there.
Yeah, thank you for this. This is quite amazing. I'm a sixth-year med student, and I have also always been interested in first technology, and then I think in some future will introduce myself to the world of investigation. I think on one side it's quite difficult for us to understand all these concepts independently on what basis you may have previously acquired on your own, when your teachers don't even recognize or are not able to understand that when the screensaver pops up, the computer has not broken down. And then, what should the pathway, someone interested in all this stuff, or at least investigating in medicine plus, combining new technologies or informatics, what is the way one should follow, obviously outside the career, hence trying to combine it with clinical activity to some extent. Thank you.
I guess that you can have formal training or education after your medicine career. You can do another career. You can do a master that now are very broad, and I guess that you can train or learn about technology or engineering approaches. And of course, that's like life. If you have a hobby, you dedicate time to that hobby and you learn that. But I guess that, as you said, to get to these approaches to get incorporated in teaching, in medicine teaching, we will have to have a generational change with new generation like you, speaking about this and integrating this kind of approaches in their explanations. But yes, like that's my answer, yes.
Good afternoon. First of all, I want to thank you all for today. It was great to listen to you, and all your opinions we truly appreciate them. I would like to ask you, what is your opinion of how artificial intelligence could be introduced in medicine without being only developed and thus monopolized by the big companies? If a software of certain risk must be approved by the FDA, and it has to go through clinical trials, and that involves a significant amount of money. In other words, how can university research can be transferred to the real world? Thank you.
I think that it's not easy, of course, because first of all, when we are working with new algorithms, we don't know what we are expecting, okay? So until you don't have the data, you don't analyze it, you don't start to work with the first prototype, maybe you have to develop that, it's hard. So I think that in this beginning, at least from universities and public centers, we are tending to work with public funding. So there is no other way. So if we later want to transfer this, I think that to get private funding, we need models that are trusty, that you are confident with the solution, that you can provide a model that you can be sure, okay, that this is working, that the performance is going to be good enough, that you can explain why your machine is working and not, okay, what is relevant for the machine, all the things that we were talking at the beginning of the day about, okay, I want a model that is not only able to provide a accurate solution, but also to explain which inputs are providing this output, all this stuff. And this is no easy, and this is no easy because in this field we need a lot of data that are difficult to have. Because in other fields, okay, there are many applications right now where the machines are working better than experts. So, because in that cases it's easy to get data, we are getting information from internet. So, in some other cases, maybe it's easier because of that. Here, I think that first we have the main challenge that we have is the data acquisition. So we have to start to think that maybe in the universities, I think that in the last year has been a change of mind and we are starting to share the code, okay? When we are publishing our papers or our research, we publish the content, the mathematical details, the algorithms, but we also include our repository with the code, okay? We make it free because we want to share. We are starting to think that is the right way to work, the right way that our work is known, is used, at least by the research community. But I think that we have to start to think that if we want to change this also in other fields, the data has to be a compliance, has to start to be open so that we can start to have models that really we can trust them, that we can be confident, that they are accurate, that when you use this model in another center, the result is going to be good. To get that, you have to train the model in a multi-center, and those kind of things right now I think that are quite hard because you need money. So, and if you need money and if you need private money, the first thing that you need is a model that is working. So I think that is a cycle that we have to stop at some point if we want to have what you are saying, really the innovative, the transference from the universities and from the research to the real product.
Any more questions? No? Okay, thank you very much, Ismael, Vanessa, and Iñigo. I think we've had an excellent conversation today.